Good morning, everyone. It's Friday, October 1st. Nephrology Grand Rounds. We'll go ahead and get started since we have three speakers this morning. First will be Dr. Shannon, followed by Dr. Gorbatkin, and concluding will be Dr. Blosser. So without further ado, I'll turn things over to Brendan. Go ahead, Brendan.
Hi, I'm Brendan Shannon. I work at Harborview, where we have a kidney genetics clinic in concert or in association with medical geneticist Zach Chambersert and Brian Lynch from UW, where we see a lot of PKD patients. I was originally going to talk about sort of all the complications of PKD, but that became kind of an excessively large topic, so I'm limiting the talk to complications that occur outside of the kidney. So I'm going to address hepatic complications, which is the most common extrarenal complication. Talk about the pancreas, which is sort of an obscure topic, but worth knowing about. The brain, which is the most deadly complication of PKD. And then I have one slide on some of these obscure extrarenal features that mostly exist at the case report level. So ADPKD is caused by pathogenic variants in two genes, PKD1 and PKD2, that make the respective proteins polycystin-1 and polycystin-2 that, at least in the kidney, associate together and seem to form a complex that is involved in regulating intracellular calcium levels, and when mutated, results in increased cyclic AMP levels activity inside kidney epithelial cells. They're also expressed, though, in the endoplasmic reticulum, and they're expressed in endothelial cells and vascular smooth muscle cells, both cilia-associated and not. These are electron micrographs that I took of primary cilia in mouse kidneys. Each epithelial cell in the kidney has one primary cilium, so they're kind of hard to find on EM. In the kidney, they seem to play a role in mechanotransduction and sensing tubular flow, and it's thought that they serve a similar role in the bile duct, where they're also found. But their role in other organs, like in the endothelium and vascular smooth muscle cells, is really less clear. They actually have a fairly wide distribution of expression at the protein level. So they're found not only in the kidney and liver, but really in a diverse variety of tissue types across the body. This is for PKD1. And similarly, PKD2 has even a broader and high-level distribution in other organs. So I'm going to start with a case of a 37-year-old woman that had ADPKD, and she had imaging classification 1B, meaning she had somewhat lower risk of progression of her kidney disease. And you can see this by her 13-centimeter kidney, which has interspersed with the bright areas on MRI that represent cysts. There's lots of dark areas representing healthy kidney tissue, but you can see her liver is pretty big. As you scroll through her CT scan, you can see that her liver actually occupies the majority of her abdominal cavity. Her creatinine's 0.9, her bilirubin's 0.5. She has normal AST and ALT. So again, the liver is the most common site, the most common non-kidney organ that's involved with PKD. The prevalence of hepatic cysts has ranged of 67% in a Spanish cohort, where their ability to detect cysts was 3 millimeters by ultrasound. But as you get older, the prevalence increases. So above age 20, they're found in 81%, and over age 40, actually 95%. An MRI, using MRI, and the CRISP cohort, which is this radiologic screening multi-center group that had mostly patients with preserved kidney function. Over age 35, you could find liver cysts in 94%, where the detection limit for the cyst size was 4 millimeters. And the cyst burden increases with age, and it's also tends to be greater in female sex. So early on in life, the involvement tends to be mild, but it can increase in number and size over time as people get older. As far as the pathogenesis, the cysts develop from cholangiocytes, which are the cells that line bile ducts, and they express primary cilia as opposed to hepatocytes, which don't have primary cilia. The pathways seem to involve altered Wnt signaling and, like in the kidney, increased intercellular cyclic AMP. And also like in the kidney, the bile duct epithelial cells undergo increased proliferation and increased secretion. As far as risk factors for cyst development in the liver, no difference in mutation type, whether PKD1 or PKD2 was found in a cohort from Mayo, but a group from Tokyo recently published that PKD1 truncating variants had a higher liver cyst burden. And this is also the types of genetic variants that are associated with worse kidney disease. Age is a risk factor. Again, they increase in size as people get older. And then female sex before menopause tends to have higher cyst burden. And there's also this association, the sex association is explained by possibly a relationship to estrogen exposure. So there is somewhat of a relationship with the number of pregnancies that people have had and if they've been exposed to estrogen-containing oral contraceptives. And in the CRISP cohort, the number of cysts wasn't increased in women, but the volume was. So the average volume was 5 milliliters in women versus 2 milliliters in men. This is from a cohort from Colorado published in the mid-1990s, where there was sort of a dose-response relationship between whether women had been pregnant or not and the number of cysts they had. So if someone had no cysts, only about 60% of those had been pregnant, whereas if you had more than 15 cysts, the overwhelming majority had been pregnant in the past. And there's some data supporting the oral contraceptive exposure increases cyst burden. There's sort of this weak relationship where for every 10 years of estrogen-containing birth control pill exposure, there's a 15% increase in total liver volume adjusted for height. People that have hepatic cysts, about 20% will develop symptoms. The most common is chronic abdominal pain. Back pain is common. As cysts get bigger and bigger, dyspnea can be present, early satiety, acid reflux, malnutrition, and in severe cases, even hepatic venous outflow obstruction and IVC compression. In most cases, LFTs remain normal. They can become elevated in 2 to 5% mostly when there's hepatic vein involvement. And it's most common to see GGT and alk-phos being affected more than the transaminases. Interestingly enough, about 45% can have CA19-9 elevation, and the degree of elevation tends to correlate with liver volume. There's various patterns of liver involvement. This is a classification schema called the Gijo classification, where type 1 would have a few really large cysts that tend to, a few really large dominant cysts. Type 2 is a more generalized involvement of the liver, but with significant areas of healthy liver tissue interspersed. And type 3 is a more diffuse involvement, but with not a lot of healthy liver tissue. So the treatment options in people that develop severe symptoms from liver cysts include cyst aspiration or sclerotherapy in the type 1 cases where you have sort of limited large dominant cysts, laparoscopic fenestration procedures for selected cases that have this type 2 pattern, partial hepatectomy for some of the type 2 and some type 3 patients, and then octreotide analogs for patients with a type 3 pattern. And then finally, liver transplant if there's really refractory symptoms in type 3 patients. This is an illustration of sclerotherapy or aspiration in sclerotherapy. So again, this would be used in patients that have maybe 1 or 2 dominant cysts that you really suspect are responsible for symptoms. So the cyst content, this is done with interventional radiology. Cyst contents are aspirated and then injected with a sclerosing agent, most commonly alcohol. The surgical procedure fenestration has the advantage of being able to treat more cysts. It's also more invasive. And basically just laparoscopically, each of the cysts are unroofed. How successful is aspiration and sclerotherapy? There's a systematic review that covered 526 cases, and this is not just in PKD patients, this would be all liver cysts. And they were pretty successful at reducing cyst volume. The range was between 76 to 100% reduction. 72 to 100% of cases noted improvement in symptoms, complete resolution, generally in over half, but there was also a high rate of recurrence of cysts up to 80% and recurrence of symptoms in about 50%. Partial surgical treatments, partial hepatectomy and fenestration, you might consider that in a patient like this where they have kind of massive involvement of some parts of the liver, but some healthy liver tissue remaining. But in someone like this where it's really diffuse involvement, surgical options aren't going to be there. Surgical options, most of the data reports outcomes on volume reduction where they tend to be a lot more successful than sclerotherapy. The outcomes reported on quality of life are somewhat limited. There's an interesting report recently published from Mayo where their primary outcome was actually pain relief. And they reported on 18 patients that they had operated on over a 4-year period, which kind of gives you an idea that this is not a super common procedure. And they reported the SF-12 scores after 6 months, and they improved on both the physical component score and the mental component score from 24 to 45, 40 to 55. And this is pretty much approaching the kind of results in the general population. And then they had this quality of life instrument that was focused on polycystic liver symptoms, and they improved in 15 out of 16 components. Interestingly enough, the pain complaint did not. That was the one area that did not improve. So for people that have more diffuse involvement, there are medical options, namely octreotide analogs. And the options here are lanreotide and long-acting octreotide. And on average, they can reduce cyst volume by about 5%. So they work by activating somatostatin receptors, and the mechanism is thought to be that they reduce intracellular cyclic AMP in the bile duct cells. Their effect on quality of life and symptoms is less clear, though. There's been 10 randomized controlled trials that are mostly small. The largest had about 300 patients, and only 3 of those trials reported any quality of life outcome. And the one that did had, or one, for example, one reported improvement in only 2 of the 2 SF-36 subdomains where the physical role and bodily pain component improved slightly. The downside to the medical therapy is that they're expensive, and the range is about $10,000 a month. And then finally, kidney liver transplant is an option for really refractory cases. Using the UNOS database from 1988 to 2013, 107 patients have received combined kidney liver transplants for this indication. The great majority were female, 78%. And most of them still have preserved hepatic function by lab measures. So most of them have to be listed using MELD exclusion criteria. And the most common indications for pursuing the liver transplant were ascites and portal hypertension, cholestasis, recurrence of infected cysts, and then malnutrition. This is a survival curve, and you can see they're pretty low numbers, but this is the curve for the combined liver kidney and PKD. This represents the curve in people that received liver transplant alone that had polycystic liver disease, and this is all combined kidney liver transplants. So they tend to have better outcomes than these other categories. So again, if you have a really large dominant cyst that you think is causing symptoms, you might consider the aspiration sclerotherapy as an option. And if you have multiple large cysts, especially if they're located in the anterior segment, but you have some reasonable degree of preserved hepatic architecture, you might consider fenestration. And if you have a more segmental involvement that you think is pressing on organs like the stomach and causing a lot of symptoms, you could consider partial hepatectomy. And then somatostatin analogs are considered for people that have moderate to severe polycystic involvement with significant impairment in quality of life and a relatively rapid growth in liver volume exceeding 5% a year, and or having other complications. And then finally, liver transplant is reserved for really severe refractory cystic involvement and major impairment in quality of life or untreatable complications. So this patient was referred to hepatology, and she's been on lanreotide for about a year now. It's resulted in kind of significant improvement in liver volume, where her liver went from 4,600 milliliters to 4,200 milliliters over a year time. And again, the average liver volume for a female is about 1,300 milliliters. So just gives you an idea of how large her liver is. But she still continues to have difficulty standing during her job, has a lot of early satiety, has had an unintentional 20-pound weight loss over the last year. And so she was just recently referred to hepatobiliary surgery at UW to discuss surgical options. And both Ray Young and Jim Park have a fair amount of experience in treating these kind of cases. Pancreatic cysts are a little more of an obscure topic, but they're not exceedingly rare. A screening MRI study of 100 cases found them in 36% of patients with PKD. And they found that the PKD2 genotype was overrepresented if you had a pancreatic cyst. A series from Mayo that was recently published of 271 patients that had genotyping and MRI screening found pancreatic cysts in 19%, but there wasn't any association with the genotype. The lead author on this was Barbara Nicholas, who's the alumni of here. And the thing to know about pancreatic cysts is that unlike cysts in the liver and kidney, pancreatic cystic lesions have malignant potential. It's exceedingly small. If the cysts are, plain cysts, can occur in like 17 out of 100,000 cases. So if you have a plain pancreatic cyst, it is recommended to get some follow-up imaging. And if they're less than 3 centimeters, this would just involve repeating the MRI in a year, and then 2 years after that, and then one more time 2 years after that. But there is this subtype of pancreatic cystic lesions known as intraductal papillary mucinous neoplasm. And this was found in about 1% of the Mayo series. And what these are pancreatic cysts that communicate with either the main pancreatic duct or a branch of the pancreatic duct. And they do have malignant potential. They do have a higher malignant potential. In the general population, up to 70% of the main pancreatic duct lesions can be malignant. And main pancreatic duct have a higher malignancy potential than the branch duct. So in this Mayo series where they found the IPMNs in 12 patients over 10 years of follow-up, 2 of them ended up progressing to the point where they needed Whipple operations, and then that was recommended an additional person that declined treatment and ended up dying from bowel obstruction caused by the IPMN. And this is just sort of an illustration of what they look like. And then kind of a brief slide on random other extrarenal features. Arachnoid cysts are pretty common, usually have no consequence. Diverticulate and widely reported as being more common. It's a little controversial. It's also exceedingly common in the general population. Mitral valve prolapse does tend to be more common. Pericardial effusion has been reported as an association, as have thoracic aortic aneurysms. So I'm going to switch to a different case that we saw. This is a 45-year-old man who happens to be an amateur pilot. He has kidney imaging classification 1C, so he is at a higher rate of progression of his kidney disease. Currently has a GFR of about 45. So he underwent brain MRA screening for cerebral aneurysms with the non-contrast study that found this little ditzel in his right internal carotid artery. Shown in a different view here, this was a 2 by 4 centimeter internal carotid artery aneurysm. So intracranial aneurysms are increased in frequency in PKD compared to the general population. And it's something, it's the frequency ranges from 4 to 14% in PKD versus something like 2 to 3% in the general population. So at least like 4 to 5 times probably the frequency in the general population. If you have a family history though, and a first-degree relative, the frequency increases to 22%. The risk of rupture seems to be similar, to what's found in the general population. But rupture in PKD occurs at a younger age, like on average about age 40, compared to the 50s in the general population. So there's the issue of screening for aneurysms in PKD. A KDIGO guideline published in 2015 for issues with PKD recommended screening with MRA is between 18 to 40. If you had a family history, a previous rupture, if you're in a high-risk occupation, or if you're just sort of anxious about it and wanted it. And then they recommended screening again every 5 years. And intervention would generally be considered if the aneurysm is greater than 7 millimeters. So a few recent publications to kind of illustrate this. From France, 500 patients, a cohort of 500 patients, 110 of those had a positive family history that they recommended screening for. 90% of them agreed to get screening. And so they had 6 years of follow-up on those patients. And they found 14 aneurysms in the 100 that they screened. 9 of them they decided to watch. 5 they looked bad enough that they underwent prophylactic treatment. And the people that were treated, there was no rupture. And the 9 that they were watching, unfortunately, 1 had a rupture for an overall rupture rate of 2 out of 1,000 patient years. 388 of their cohort did not have a family history. 81 of them wanted to have screening anyway. And in those, they found 5 aneurysms for a detection rate of 6%. 4 they decided to watch, 1 that they treated. And none of those had rupture. 76 had no aneurysms on initial screening. 1 ended up having a rupture. And of the 308 that weren't screened, 3 of them ruptured. So for the same 2 out of 1,000 patient rupture rate. In other words, whether or not you had a family history or not, the rupture rate was the same. So one argument for doing universal screening is that, like in the French study, 80% of rupture rates occur in people that don't have a family history. And they use their data to suggest that the benefit of screening would buy each individual 1.29 quality adjusted life years versus no screening. And if you compared universal screening to targeted screening, where you'd only screen patients with a family history, it increased quality adjusted life years by 0.68. And so this group suggested doing universal screening, starting at diagnosis and repeating it every 5 years. If you found an aneurysm, then to monitor annually for 5 years. Another study recently published from Mayo looked at 812 patients that had a family history. They found aneurysms in 75, or about 9% of their cohort. 7 of the 75, they decided were bad enough that they would do preemptive treating with clipping or coiling. None of those sustained a rupture. And this is over about 9 years of follow-up for median follow-up. And the 700 some that didn't have an aneurysm on initial screening, 2 ended up having a rupture. 1 was a 54-year-old woman that had been screened 17 years later, had an aneurysm found, or had headaches, had an MRI, had an aneurysm found, and then 5 days after her MRI developed a rupture. Another was a 29-year-old woman that was on dialysis and had been screened 11 years prior and had no aneurysm then, and then died of an aneurysmal rupture. So the treatment methods, if you do detect an aneurysm and you want to treat it ahead of time before it ruptures, includes coiling, where the lumen of the aneurysm is occluded. Coiling supported by a stent if the neck of the aneurysm is wide enough that a simple coil won't help. And then doing a flow diverting stent if the characteristics of the vessel are such that you can't place a coil. And then finally, surgical clipping, which is an open surgical procedure requiring craniotomy. So how do people do? The short-term mortality of coil versus clip is relatively reasonable. Procedural complications involving aneurysm rupture occur in just under 2%, and then thromboembolic strokes are more common actually in coiling, up to 7% versus clipping about 4%. This is a meta-analysis, about 30,000 cases in the general aneurysm population, not just PKD patients. And what about the cost effectiveness? If you assume that an MRA costs $1,000 that coil embolization costs $31,000, that the prevalence of aneurysms in your PKD group is 11%, and that the annual risk of rupture is 0.4%. The mortality, if you sustain a subarachnoid hemorrhage from aneurysm rupture, is 30%. Then universal screening would buy you 2.3 quality adjusted life years compared to no screening, at a cost of about $70,000 per quality adjusted life year. In other words, in line with what are generally accepted costs for procedures. So back to our case, he ended up undergoing catheter angiography about a year later that showed this 2.6 millimeter hypophyseal artery aneurysm, which is a branch of the internal carotid artery. This shown in kind of a better, prettier picture. So in other words, it was stable in size. The surgeon recommended, or the surgeon thought that this kind of lesion at this size and location would have about a 0.1% annual rupture risk that he thought would exceed the risk of treatment with coil that would involve maybe 3 to 4% risk of stroke or bleeding. So the surgeon recommended an MRA non-contrast every year for the next 5 years, and if it continued to remain stable, just repeat it in 5 years. So the pros for universal screening, they definitely have it has the potential to prolong survival if you find a large aneurysm that's at high risk of rupture. The cons is that you expose someone to procedural risks, and even if you find a small aneurysm, you do run the risk of additional medicalization of someone's life and give them one more thing to worry about, I suppose. So in summary, don't forget to consider the liver as a source of abdominal pain in addition to the kidneys. And there are treatment options for pain related to liver cysts other than narcotics. And the options kind of depend on the specific anatomy of the hepatic cysts. I would think of contraceptive options other than estrogen-containing birth control pills for people with hepatic cysts. And if you do detect a pancreatic cyst, it actually should receive some kind of follow-up. And then you should screen for intracerebral aneurysms, whether you decide to do universal screening or only screen in those with family history, I suppose it's up to you. I mean, there's not a clear-cut argument based on the data. We've decided in our clinic to do universal screening, and the screening is done, it's recommended to do at diagnosis, basically greater than age 18. And it's done with an MRA. The best probably is with an MRA and doesn't require contrast for that. And guess I'll pause if there's any questions.
Thank you so much, Brendan. We have time for a couple of questions, and people feel free to use the raise your hand function or type in the chat. Brendan, when you detect an intracerebral aneurysm, are you referring to neurosurgery?
Yeah, I think that's a really good point. So I wouldn't make that call, like what kind of follow-up they need on your own, because it really is kind of individualized. I mean, these sort of, cohort studies talked about annual follow-up and stuff like that, but I would really get the opinion of the surgeon, because the risk of rupture is not totally dependent on size. I mean, the size is a big factor, but there are other characteristics of the aneurysm, like how wide the neck is, if there's a so-called daughter aneurysm. There are other factors other than size that can increase the risk of rupture. So I would definitely establish a follow-up plan in coordination with the neurosurgeon. And in contrast to that, if you detect hepatic cysts and you refer someone to sclerotherapy, that's going to be pretty much your call. So I think you have to decide on, whether it's something that's likely to benefit, and think about, recurrence risk.
So you don't necessarily think that there's a benefit of referral to hepatology, for example, for their opinion in those cases? I mean, is that something that you...
Oh yeah, no, I think you definitely could do that too. Yeah, that's probably, that's a good point. And that's, the person that was treated with lanreotide was done through hepatology.
All right. Well, thank you so much, Brendan. I learned a lot.